Thank you. Good morning, ladies and gentlemen. Anterior choroidal artery is a small but supplies the corticospinal tract. Once damaged, it can cause a very much serious problem, as you know. 3D DA is mandatory to reveal the relationship with the aneurysm and anterior choroidal artery, but not enough to show everything. So it requires a strategic neurointerventional approach to avoid risk to compromise flow into anterior choroidal artery as an acceptable option when especially surgical clipping was proposed. Our recent series published in KJR almost 1,000 aneurysms. The goal was the paper is to reduce treatment risk down to the outpatient procedure level. As you see the outcome below, among them, anterior choroidal artery was 81 cases out of 956 cases. It means 8.5%, a little much more than the usual 3% incidence among the aneurysm. When I moved to another hospital, we did 240 cases during recent 2 years. Among them, 18 antichoroidal aneurysm was treated. In this talk, I tried to mention basically stent-assisted coiling principle. Based on our experience, we try to set up some specific strategic point how we approach to the anterior choroidal artery aneurysm. Stent-assisted coiling is the basic, as you see here. The follow-up MRA showed a good result. First point is that low-angled approach, as you see here, below the aneurysm, in front of the anterior choroidal artery. As we published before, the upper one, when enter higher, then coil goes down and compromise the origin of antichoroidal artery. So introduced a lower level and then push the coil a little upward. Second point is it requires almost two different angle view. Otherwise, it can confuse where the antichoroidal artery is. As you see here, at one angle it looks compact coiled, but the other angle there is some loose space maybe. So to make a balance between two angles is necessary to get a secure result. Even if there is a small remnant at the neck, the follow-up result is good. Let me show you the basic principle here that usually is stent first. And then low line approach, microcatheter approach in the lower level of the aneurysm, and then push coil upward and then make a little steeper frame between the stent and the aneurysm wall to make a triangular shaped vacant in front of the anterior choroidal artery aneurysm. If it fails, it's almost difficult to try to embolize the aneurysm. And then finally packing the aneurysm. For this peculiar antichoroidal aneurysm, I don't have a pointer here, so maybe you can see well. Antichoroidal artery in the left side is separate from the aneurysm, but in the other angle, it comes out of the aneurysm. So it means that if we embolize it, we should make a triangular shaped vacancy a little larger area. Even 3D angio couldn't show that relationship exactly. So between the stent and opposite wall, this kind of vertical framework would be necessary to make a rather rigid frame making to protect inflow into the aneurysm. Then a vacant area may remain stable even after remnant of the neck or even set part of sac. This ugly aneurysm looks become after 3 months. Further follow-up would be necessary. Another point is interaneurysmal angiography, which can show the exact entry point of anterior choroidal artery. So recent 2 years, some other method like coiling only, stent only, there's some recurrence and retreatment I show you. This multiple aneurysm in right M1 and the incidental right anterior choroidal aneurysm, just 1 or 2 coil would be enough without any stent use. This is ophthalmic aneurysm and associated with anterior choroidal artery aneurysm, which was very ugly shaped on the lateral 3D angiogram. In the middle, anterior choroidal artery is arising from the ugly looking anterior choroidal artery aneurysm. The first target was the ophthalmic aneurysm. But we cannot the anterior choroidal artery remain as it is. So stent was covered anterior choroidal artery aneurysm, but anyway, the aneurysm looks stable for the 19 months follow-up. As we reported, low metal wall aneurysm even can get a flow diverting effect. These two aneurysm, the below one is anterior choroidal artery aneurysm. The medially there is an anterior choroidal artery. So, we thought we packed well, but at 3 months there is some small filling in the aneurysm, and 15 months later there's a bigger recurrence there. So when we get the 3D angio, there is a large recurred space within the coil mass. So we packed another coil mass, but a little larger coil mass to get the framework into the recurred aneurysm. So even if we packed enough, but without making a strong frame at the neck, it may cause a recurrence in the future. So after 3 months, it was stable. Coiling only, we experienced recurrence. It's a tunnel-shaped aneurysm neck. We coiled because at the tunnel-shaped neck there is a triangular-shaped anterior choroidal artery was arising, so it's difficult to make a vertical framework between the stent and the aneurysm. So, and then a small remnant of neck and the sac looks bigger during the 17th follow-up, but looks stable. So we'll follow more anyway. So in conclusion, stent assist coiling is the basic, but if possible, coiling or stent only can be applied. Aneurysm often arises in the aneurysm sac. That's the erase the technical key to formation of a new aneurysm neck to keep a channel for the anterior choroidal artery flow by combination of coil frame formation against the stent, microcatheter low-angled approach angle, and then intra-aneurysmal angiogram. Thank you for your attention.